Good day, listeners and viewers. Welcome to the Open Wound Research intro to the fourth episode of the podcast. Today we have the great Pamela Scarborough is joining us, and Pamela is well known in the wound care community as a fantastic educator and advocate for patients and clinician education. Today she goes into education, her origins in wound care, a little bit of a bio, and talks a fair amount about end of life and diabetic care. And I think it is an absolutely fascinating interview, and I think viewers and listeners will enjoy it bar none. So please enjoy the episode, and as always, if you have any comments, etc., please send them to us via email, our blog, our website, or any of the other platforms with which you can communicate with us. Hello, my name is Zweli Tuniswa, CEO of Open Wound Research, and with me today I have the great Pamela Scarborough. How are you doing today, Pamela?
I'm doing wonderfully, Zwelly. Thank you for asking.
It's such a great treat for us to have you on the show today. I've been really looking forward to speaking to you and kind of getting into that great mind of yours as it regards education, end of life, pressure ulcers. I just think you have so much great information that I think the viewers are going to find valuable today.
Thank you. I hope so.
So, by way of a quick introduction, Pam's background is that of graduating from the University of Montana with her doctorate in physical therapy. She's also a graduate of the University of North Texas, where she got a master's of science in health promotion, wellness, and exercise physiology. She's been a denizen in the world of wound care education. I think pretty much everyone in wound care has, in some way, enjoyed her educational content over the years. And perhaps as a first step, Pamela, where did you grow up and how did you get into the sciences?
All right. Well, thank you very much. Where did I grow up? I was born in Alexandria, Louisiana, so I am a Southern girl through and through. In my early teenage years, moved to Texas. I've lived in Texas the rest of my life, lived in Dallas, Texas for 45 years, married to a lovely gentleman, rearranged my marital status after 25 years, and moved to the hill country of Texas. So at this point, that's where I live in Central Texas.
Great old Central Texas. Big state.
Yes. In a
And
small village called Wimberley. Yeah,
Wimberley. Uh,
Wimberley.
uh, Wembley. There's a famous football stadium in England called Wembley. That's how
Ah,
I know that. Yeah, so it's not unknown word to me. So you grew up in born in Louisiana, moved to Texas.
mhm.
You what? How did you decide on science? What was it, a familial thing, or did you just have an affinity for science?
Well, I'm a lifelong learner and continue to this day. From the time I was a very young person, I have been a lifelong learner, and I wanted to be able to be in something that I'd be able to learn in. So I was looking at the medical profession. However, I was a single, unsupported mother when I had to go through school, and I was trying to find something that I could take care of a child and go through school. And physical therapy worked out for me. The profession of physical therapy, and it's been a fabulous profession. So after I finished school, I did what I call fellowships. We didn't have fellowships in physical therapy at that time. And I did three different types of fellowships, one in acute care, one in sports medicine, and then one in spine care. So I did about 3 years in what I termed my own fellowships. And while I'm in those jobs, I'm learning, I'm uh, taking courses. So over the first 20 years of my career, I consider myself a generalist with experience, as I mentioned, in sports medicine, back and spine rehab, general orthopedics, cardiac rehabilitation. Had a wonderful long stint in cardiac rehab that really helped me to get my arms around not just the heart, but how everything is affected by things like diabetes and heart disease. And also during that time, when I was working in cardiac rehab, 50% of our patients had diabetes. So there were three of us that decided we were going to become board certified diabetes educators. And I was one of those. So I was a diabetes educator for 20 years. So the clinical practice that I've done, in addition to that, I've done it in acute care, outpatient care, home health, long-term care. So I've done this across the continuum, and these different perspectives in clinical practice across these different care settings have gave me a great foundation for my focus in wound prevention and management, because one of the consistencies across all of these care settings, all of these particular types of physical therapy practice that I would do, all of them had wounds. But wound was not a focus. They were incidental to my practice. So in the 1990s, in the late 1990s, I had this beloved pet, a Skipper Key dog named Smokey. Smokey was hit by a car. He had brain damage. He lost the use of his two front legs. So he ended up opening up his little elbows. I don't know what we call them on dogs, but the joints in the front of their leg. And he opened one up to where it was down to the bone. And it took me months to get this closed. And he ended up with a functional 3 legs, went to his grave with 3 functional legs, and he was at the highest level of function he could be. So this experience with this dog, now remember, I've been doing wound patients, but it was something about this that tipped me over the edge that had to do with this cherished dog. So this experience, I knew that I needed to have more understanding, more knowledge related to wound prevention and management for my human patients, and decided to start a focused journey to find mentors, to find courses, to find research, to expand my knowledge and care for people with wounds with a higher level of knowledge. And one of the differences, and some people may not think about this, between education and knowledge isn't education. Knowledge is what you do with education. So yes, I'm an educator, but that doesn't mean that you're knowledgeable. Once I provide the education, you have to take the education and internalize it and make it your knowledge. So education and knowledge are 2 different things. And I was on my journey for knowledge to care for our patients with a higher level than I previously had. So I found people to mentor me. I found the courses, I found the conferences where I could learn and take that knowledge back to my clinical practice. All of us, all of the clinicians who come to wound management, we come through different pathways. Rarely, but sometimes, but rarely, a clinician knows they want to do wound management from the start of their career. Most of us have worked in healthcare for a while before we realize the joys and challenges of being a wound specialist. For that's what we are. This is a specialty. Cardiology is a specialty. Wound management is a specialty. And it should be respected as such. So we're wound specialists. This is a healthcare specialty, and it requires targeted training and education to get the knowledge and skills that you need. So after I went on this journey and realized that wound management education was not specifically taught in nursing, our medical schools, our physical therapy. That wasn't, you could go become a nurse wound specialist, but it was after you got out of your school. So what was happening is all of us were coming out and we're seeing wounds and we're doing wounds, and we don't have the knowledge to do it. So in 1998, I partnered with another physical therapist, Bonnie Sparks, who, by the way, went back to school to become a nurse and to specialize as a WOCM, because the physical therapists were being pulled out of the wound teams. Don't know exactly why. It's supposed to be interdisciplinary, but it ended up being a physician-nurse model. And the therapists some of them were taken out around the country. And Bonnie made the decision that she was going to change her profession so she could stay in wound care. Now, that is a commitment to a specialty. And I always respected her for that. So Bonnie and I started a wound course in 1998. And that continued. And then in 2000, I decided to take the board certification as a CWS. I took one of the first exams. Before that, you portfolioed in. I didn't want a portfolio. I wanted to do the exam. Well, I thought I knew wound care. I really did. I'd been teaching it for several years. I'd taken courses. I studied the outline of the topics for the exam and barely passed. I passed by 1 point, Zoe. 1 point. That taught me what that taught me. It took me 20 years to even tell any of y'all that I passed by 1 point. At that point, the fail rate was about 40%. So with my borderline result, 1 point, I knew there were large holes in my knowledge. And knowing that others, if I had this, and I'm teaching this stuff, that others were going to need support also, but support to pass the exams. We need more credentialed wound specialists, not somebody that decides they're going to stop being whatever kind of clinician they are, hang their sign that says they're a wound specialist because they have some type of medical degree. That's not enough. It is not enough. And those people are hurting people. Those clinicians are not getting the outcomes because they don't have the knowledge. So I had large holes in my knowledge, that I felt I had to get plugged, and I did that. And then I found two other people that have the passion for this that I do, Dot Weir and Greg Patterson. So I invited Dot, who's a nurse, who she already had her WOCN certification from the Wound Ostomy Continence Nurse Certification Board, and Dr. Greg Patterson, who's a surgeon in the Georgia area, who was a surgeon and a wound physician. So we got together, the three of us, the physician, the nurse, the physical therapist, and we wrote an interdisciplinary wound course to prepare people for their board certification. That was the first reason we were doing it, Swelly, is to get people ready for their boards so we have more credentialed specialists who have gone through through an accredited, the key term there is accredited board certification. So we were involved in this course for, we've been, and Dot and Greg, let me mention this also. Before Dot and Greg um, could teach the course, I was very strict. They had to get their CWS. They had to go take their board exam to be able to teach the course with me. And they did. And they passed. And I never asked them what they passed by. And Dot didn't know what I passed by until just recently. So the point is, in 2004, in 2003, I locked us away. Early 2004, I locked us away. The three of us sat down and wrote this course based on the American Board of Wound Management outline, which was one of the most comprehensive interdisciplinary outlines that I could find for wound management. We started the course, we piloted in New Orleans in 2004, and the feedback from this pilot was so positive that we continued the course. I produced and taught the course with Dot and Greg for 10 years, and then in 2014 sold the course to a publishing company that also had conferences around the country. The name of that company is Health Management Publications, who graciously invited Dot, Greg, and I to continue to teach the course. We have added other faculty. We have a larger faculty now, but the three of us have been teaching this course for 20 years, and the course is going on for 20 years. We're going to be at SAWC Spring coming up, and you can come and take it live in person, or you can take it as a webinar. So this course has two purposes. One, the first purpose was to get people ready for their CWS exam, because at that time, the American Board of Wound Management had one credential. Now they have three. At that time, they had one. So that was the first reason, to get people ready for their boards. The second reason that we found later, as people were coming to the course that didn't know wound management, one doctor says, they want me to be the medical director, and I don't know anything. Thank goodness the nurses that hired him said, you have to go take a course before you can be our medical director. You go, nurses, love it. So we found out that people were coming to this course to get a background. It's intensive. It's a 21-hour course. 17 is of the hours are in person, and the other hours are self-study. So it's a 21 hours intensive course to get people educated, the education, as quickly as possible. It is an intensive. And that was the second reason that people came. The first was for the exam. The second is for them to get some knowledge on, to get an education for wound management and have more knowledge. In addition, I've taught industry wound partners. We have industry people from different companies that become board certified wound specialists so that they can talk to their clinicians with a higher level of knowledge. It worked out very well for our industry partners. I've taught in the Doctor of Physical Therapy curriculums for several schools, for state and national healthcare associations, particularly for long-term care, for post-acute care corporations, for even individual facilities. I've even taught to surveyors to help the surveyors understand what they're surveying on. They have the regulations, but that doesn't mean they know wound management. They just have the regulations by which they have to go by. So that's a little bit about my background. In addition, I've written about wound management for about the last 20 years, and it is it's been a wonderful journey, Zoe. A wonderful journey. Yeah.
No, your origin story is very interesting because my old business partner, were at the wound care consultancy that we used to be partners in. Her origin story, she had treated wounds before, but it became her passion when her grandmother passed away from a pressure ulcer.
Ah.
And someone else, something
Mm-hmm.
happened to their brother with a pressure ulcer. They had been doing wound care incidentally, tangentially.
Mm-hmm.
And so it's interesting to see how someone who's treating wounds generally really becomes empowered and passionate when it strikes something very close. So when you said that, I hadn't expected a pet, but I can see that. It's something where you see this disease process destroy something or someone, and it really
Yeah.
becomes something that you can get behind. So thank you for sharing that part. It's just, as we do more of these interviews, you get these stories, these cadences that are come out repeatedly. You said an interesting thing to me about yourself. So you had been treating wounds, and you realized you weren't truly an expert, right? Um,
I'm still not an expert. I'm a specialist. I'm still not an expert.
Fair
I'm
enough.
still learning, slowly. I'm still learning.
So here's a question I have for you. As people are progressing on this continuum of expertise, right? Where do you see people making jumps? I mean, I know if someone comes in knowing nothing, they make a quick 2 week jump because they're actually thinking about this. But at which points in the sort of people's timelines do you see people making jumps from beginner to intermediate to specialist to, we'll call it expert? What kind of cadences do you see for people as you educate?
That's a very interesting question. I'm not exactly sure how to answer it. But what I'll do is I'll answer it from my perspective as I became more and more knowledgeable. The what I see with people and what I saw with myself is you have more security about what you're doing. And also we understand that, and I'll talk about this later a little bit, that we have to understand that we have to look at the whole patient and not just the hole in the patient. And I think that the education that we give helps people to understand that you have to look at all of this holistically and not, as I just mentioned, just the whole. And I see people getting this as they go on this journey. At first, they're just looking at the wound. What dressing should I use? But then as they're realizing that it's not just about wound care and which dressing you use, because dressings don't heal wounds, it's that person's body that does that. That's where I see some of the jumps when they get away from the whole and begin to look at the other comorbidities, the organ systems, and they begin to really understand where this wound came from, what might be stopping it from healing, and what type of interventions they can give. And not, we don't heal all wounds. All wounds do not heal. And again, we have to go beyond that whole and get to the whole patient. And that's where I'm seeing people really move in their practice, is when they put all of this together. And that takes years. Well, it doesn't happen in a couple of weeks. It takes years to get to that level. And it's a long journey, like in any medical profession. I think it's a long journey. And I think you go through these different time periods where you recognize that I started out with diabetic foot ulcers. That was one of the most things, keeping the foot attached to the leg. That was one of my first courses. It's still 1998, keeping the foot attached to the leg. So they'll find something. The woman who came to it from her grandmother's pressure injury, she probably went into pressure injuries first. I went into diabetic foot first. And then I recognized, oh, I need to go here and learn this. So as I said, I don't know where you see this happening exactly, but the journey goes from whatever interested you in the first place to where you get more and more knowledge. And the deeper and deeper and deeper we go, Sueli, what I recognize is the less and less and less I know. And I don't even know what I don't know. And that's all of it.
That's there's a famous quote about wisdom being realizing how much you don't know, right? And having the humility to sit there and continue learning. That's a great insight. And over your time, educating such big cohorts of providers across multiple states at national conferences, where have you seen the most prominent areas of improvement as it comes to wound care in general since you began?
Well, I was going to think about two things, but now that you put it that way, I'm going to think about three things. The first is we started getting education on this. The physicians, I don't know if they get more than wet to dry dressings for wound management, but that's kind of what they got in the past from other surgeons, wet to dry. We are so beyond that. So the education has changed. I think nursing is getting more education for wound management, and the profession of physical therapy has an entire semester. In your doctoral programs, you have to take a semester of wound management. So they actually come out with a considerable amount of knowledge. Unfortunately, oftentimes they're not getting to apply, but that's simply the way we are working right now in the United States. Some places aren't, some places are. But education has improved, number one. Number two, Zueli, there are many areas in this specialty that has grown. It's still growing, and we're all still learning. And you never know it all, even when you think you have a good handle on the knowledge. We always learn something else that changes our perspectives. My perspective has changed so many times in the first over the 40 years, but in the last 20 years about wound management. And wrapping your arms around this is on, like I said, is an ongoing journey. Whether you are a benchside scientist helping us with the understanding the biofilms, or the clinicians applying new knowledge or products or innovative technologies, all of this is important. But one of the things that I think that is particularly meaningful is the research, the emphasis on wound related research to support both wound prevention and management. It has, and it is moving this specialty in the right direction. And there's a lot that can be said for how wound research is being used by the clinical team, by CMS. Sometimes CMS uses the wound research in a way that helps us and our patients, and sometimes they use it in a way that actually causes problems and barriers for access for care. None of us are perfect, and other payer sources, but overall, the wound-related research is a driving force to understand and enhance this specialty. So that's the second one, education, research. And the third area of improvement that I think is moving this profession in the right direction has to do with our technological innovations and the applications of these incredible modalities or assessment tools to help us with wound management. So consider some of the newer assessments that we have, such as devices that can look beneath the skin, so we can tell where there's inflammation in an area before it even shows up on the skin. We can do blood flow studies at the patient's bedside or in a lab for higher level vascular studies that have gotten very, very sophisticated, down to the microcirculation practically, to determine why this wound isn't healing, and can we make a difference, open up those vessels and get this diabetic foot or this arterial wound on the lower extremity to heal. Then there's the lighting devices that we have. Oh my, talk about changing practice. The lighting where we can see the bacteria, which is located either in the wound or on the peri-wound skin, allowing for better debridement outcomes. I've seen providers changing their debridement practice with some of these lights because they can see where the bacteria is and help get that the infected tissue out of that wound bed, and help us with the wound cleansing, even on the peri-wound area. I'm using the light tool, to teach our nurses why they have to take off the scales, because of the bacteria that's under the scales that gets into that wound bed, and helps with our cleansing, peri-wound cleansing outcomes. And this, when we do better debridement, we control the bacteria better, it allows and fosters better antibiotic stewardship, which we all need to do. So these innovations are changing practice for the better.
And I guess that begs the question. We have the innovations and we have the research, and your focus has been on the clinician. When you're
Yes.
educating now, given the preponderance of all these technologies and research, how do you select which research or technology kind of makes it into your educational or pedagogical pathway? That must be kind of a challenge.
Well, it is a challenge because I'm one of those people. I love technology when it makes a difference for my patients and helps me with wound healing. For instance, I am the electrical stimulation guru for wound management. E-stim is 40, 50 years old, and we're not using it, but yet we have the evidence that shows that it's one of the most effective interventions that we have as well. So this is where research is not being used well, because it gets back to reimbursement or back to knowledge, a lack of knowledge of this particular intervention. The interventions, so I like to try them, and I'll try them sometimes when I don't even have the evidence yet. Somebody will bring something new to me where they want us to try it, maybe a company, and I'll try it to see what's happening. But I'm looking for my outcomes, and then are those outcomes that I get in my hands, are they reproducible in somebody else's hands? So that's where the research is going to help us, where we start getting the number of people that we're applying this technology to, and we're getting the outcomes. We can publish those outcomes to show that this technology really does make a difference. So there's two things when you're talking about the people that are doing the research, because they understand the technology and how it's supposed to work. And then those of us who are going to try that technology after we get the data that shows it and proves that it's going to work. And then we have to have the data to CMS to ensure that we get reimbursed. So the whole technological thing is a big concern, not a concern. It's a big topic that we want to ensure that we're not ignoring. We can't just ignore and say, go put that gauze on there. We want to look at when your body's electromagnetic system fails, and it does, you are a battery. That's what you are. You're an electromagnetic battery. And when the skin battery messes up, the skin doesn't heal the way it's supposed to. Some of these energies are changing what's happening right at the skin level. Some of them are changing what's happening under the skin level. Some of them are changing, if you're doing topical type stuff, what you put on the top of the wound. I love to be a key opinion leader. Well, I'm trying a modality, and then I give feedback on modalities. And I know quite a few clinicians that do that. And they love this because we want to advance the practice of wound management to get the outcomes that we need. And we need help. And these energies, they're energies. A lot of these are energies, low frequency ultrasound, infrared light, and some of them are topicals that you might put on that are going to change the milieu. So we need the research for reimbursement, for proving that that intervention works. But we also need the people that are willing, the clinicians and the patients who are willing to let us try these modalities on them to see if there's even a reason to do the in-depth research.
No, and that absolutely makes sense. And I love the way that, as an educator and a practitioner, you're looking at new data, testing
Mm-hmm.
it,
Mm-hmm.
replicating it, and then implementing it into your educational program, looking and interacting with the outside environment, and then having the dialectic. That's what it is, a dialectic
I
coming
like
back
it.
into your education. So that's
Yes.
fascinating. And again, points to your scientific pedigree. A question. When I was working post acute, um, we used to service 400 nursing homes, and I think maybe
Wow.
five had Eastham. And I always thought to myself, it was very interesting with Eastham. And I know I'm going on a bit of a tangent here, but if
My favorite
every,
one, Eastham,
well,
my favorite tangent.
let's go down for a little bit because every clinician I've spoken to says they love it, but five out of 400 of homes used it. I never understood it. I still don't understand it. Please elucidate that for me.
Okay, I'll try. Number one, electrical stimulation is something that has to be billed through the physical therapy practice right now. So that might be it. Remember, the physical therapists have been pulled out in many care settings of wound management. So the people I was teaching the wound certification prep course, an example. And when I got finished with, I do the section on modalities, on the energies that actually change your healing opportunities. And the physician came up to me and says, Pamela, why don't I know about electrical stimulation? And I didn't mean to be flippant, but it came out that way. And I said, because you're a physician. It's not part of their curriculum. Energies for wound healing are not part of their curriculum. So that's one of the holes, and that's one of the barriers, is that others don't know. We know what physicians can do, we know what nurses can do, but in general, everyone's saying, what is the physical therapist going to do? But electrical stimulation is one of those. Oh, and by the way, I used E-stim on that dog. I couldn't get it to close, couldn't get it to close. I started using E-stim on him, a form of E-stim, and we got him to close. And that was and I was using it on my patients for other reasons also. We were doing wound healing. We were using it post surgically, immediately post surgically, and the nurses noticed that our patients that we used it on had less pain in the hospital after their total joints or knee surgeries or back surgeries. They had less pain, and what we noticed in clinical practice is the people that we did the E-stim on, that they got back to function faster than the people that their wounds closed faster, and they got back to a level of function faster, because it also takes care of, does not just potentiate the cells and the tissues that you need for wound healing. It also takes care of edema, and it helps with pain control. So that is a little bit about electrical stimulation. I use it almost every day to this day to keep my mature female body moving the way it needs to.
It's interesting because you have an old technology that could
Mhm.
become a new technology, with the
And it
right
is.
research and
It's so
reimbursement.
interesting. Excuse me, I interrupted you. It's so interesting you mentioned that. I was doing the wound certification prep course, and we had some people that were vendors, and they brought in the new technology of electrical stimulation, which you can run from your phone. It was pretty amazing. And your electrodes don't have to be have lead lines on them. They connect through Bluetooth. So even the eSTEM technology is going to another level of sophistication.
That's absolutely fascinating. So we've talked about education, we've talked about mastery, we've talked about sort of the sentiment of technology and changing. Let's go back to the educational pathway, right?
Mhm,
Knowledge grows. And then
mhm.
I think what I've seen working with a bunch of clinicians is that the same condition may present, but they take a lot more information about the patient into consideration. So let's draw a case of diabetes.
Mm.
In your mind, how would you treat a patient who has diabetes at 10 years old versus at 65 years old? And how does that work in terms of decision making for a clinician? And sort of playing on that idea of knowledge, right? Not looking at a whole, but looking at the whole.
Well, when we look at somebody that's 10 years old versus 65 years old, first of all, you're asking what type of diabetes. Does that 10-year-old have a type 1 diabetes or type 2? And to this point, we are in a diabetes epidemic. It is continuing to grow worldwide. Most of our 10-year-olds have type 1 diabetes. I had a granddaughter who acquired type 2 diabetes at 13 years old because of her predisposition to type 2. So, what happens with our type 1 patients when we look at type 1 management? These are two different diseases, by the way. Type 1 and type 2 is two different diseases. Type 1 is organ failure. Your pancreas has failed and no insulin is being made. Type 2, it's hereditary, way more hereditary. It is genetically driven. Type 1 is not fully genetically driven, but type 2 is genetically driven. It is your DNA. There's no getting around it. And there's no skipping. There is what do we call this? An urban myth that diabetes skips a generation. Don't ever think that. Your diabetes may be delayed if you have a history of it in your family, but it usually doesn't skip. So when we look at type 1 diabetes, that's organ failure. The pancreas has failed. Type 2, you have insulin resistance at the muscle cells. You may have, over time, the beta cells fail. Type 2 diabetes is a progressive disease, and over time, the beta cells fail. I have prediabetes. I've had it for over 20 years, and I have been on a prevention program for my entire life because I have so much diabetes in my family. So when you have type 1 diabetes, if it's not managed well, you're going to end up with your complications earlier. Type 2 diabetes, most of the time, if people are managing it, you get your complications later, and they're kind of different complications even. With type 1 diabetes, I see more Charcot foot disease, for instance. With type 2 diabetes, I see more peripheral arterial disease, for instance, when we get to wounds. When we get to wound management, when we talk about the child and the adult, the whole management process is two different things now. This child's management is going to be run by their parents until the child is old enough to take over. The adult that gets it, is our job to take care of our diabetes or prediabetes as an adult. Sometimes we don't do it very well. Sometimes that child, when they get out of their home, they don't take care of their diabetes very well because they may be in denial. They maybe have resentment because they've had this disease and have to be treated differently. So when you look at the differences between a 10-year-old and a 65-year-old, again, most instances you're talking about two different diseases, two different mindsets, two different body uh, complications that are taking place. And then when we get to diabetes management and wound management, some of the things that our clinicians don't understand, and they need to, is the number one thing you must take care of for a person with diabetes with the wound. The number one, don't think vascularity, think blood glucose. Number one, get the blood glucose under control. It's not being managed well. And Zoe, I have to tell you, and I may cry right now, when I'm teaching long-term care, teaching long-term care nurses. In this particular instance, I'll ask the nurses in the audience, I will say to them, what number does your provider, primary care physician tell you to call them what blood glucose number, what level is that blood glucose? And the physician says, call me if the blood glucose is above, but don't call me unless it's above. And the nurses say 300. They call out to me 350, 400, 450. And I'm going, 500. I cried when one of the nurses said, my doc says, don't call me unless it's over 500. There's a big problem with this. Blood glucose over 200, according to the literature, the fibroblast, collagen synthesis stops or slows down at 200 milligrams per deciliter. We're trying to take care of people with diabetic foot ulcers, with wounds, and people with diabetes, and their blood glucose is 300 or 400. And you're expecting good outcomes. You start with blood glucose, then we'll go to blood flow. But we got to get the blood glucose under control. And a lot of times the wound people, the wound management people, are not taking care of blood glucose, but they recognize when it's out of control. And we need to do a better job as wound clinicians in recognizing diabetes management as part of our care plan. And that's my pitch on that.
No, that's absolutely fascinating. I've read a fair amount of research in and around elevated blood sugars and how it impacts disease processes across the board. I read one study that was talking about blood sugar and stroke,
Yes.
depression, even. And so it's fascinating you bringing that back to wound care, where yes, you are absolutely right. A lot of people will say, "Well, it's a highway problem, right?" But what you're saying is no, it's a fuel problem as well.
Fundamental problem. It's a fundamental problem. Yes. And when we look at hyperglycemia, elevated blood glucose, and I don't call it blood sugar, and I'll tell you why, Swelling. If I could change the world, I would. Don't call it blood sugar, because I've had more than one patient, including a cousin of mine, Johnny, who calls me up and says, Pamela, why is my blood glucose so high in the morning? The doctor said I had to have something by my bed at night, but I don't eat sugar. I don't eat candy. I eat watermelon, let's see, what was it? Cantaloupe. It's all carbs. He's not eating sugar. He's eating high sugar carbs. You call it sugar, your friend is going to think, oh, I'll just take the candy out of my diet and I won't have to have any problems anymore. So you have to teach them. Every carbohydrate that goes into your mouth turns into blood glucose. So I try to get my professionals not to say sugar, but to call it glucose, because we don't want to reinforce for our patients who don't know any better that it has anything to do with the sugar they eat.
Absolutely. I will make a note. Blood glucose, not blood sugar. I
That's
got
right.
it. And
Don't feel
so,
badly. Everyone that teaches with me gets the same lesson.
oh
All
no,
my,
it's
they all get the same lesson on this one.
no. I think for many people in the podcast, what we're trying to do is to educate, and trying to have people understand, what makes sense. And I'll take it as a lesson. I get the distinction, and I can see how people make that mistake. But you're right. Any carbohydrate making into the system is a sugar by definition.
That's right. Absolutely.
So we've talked about diabetes and treating patients, and that's a lot of our discussions been around how clinicians can act upon patients. I know you've worked a lot in policy as well, and that
Yes,
is
I have.
more how systems can act on patients. And I know you and Dr. Weir worked on a paper or an article on surgical dressing policy and the like.
Yes.
Could you talk a little bit about that and some of your findings and some of the other sort of articles or regulatory things that you looked at a sort of a macro system?
Wow. Because I can drill down really, really deep when it comes to the regulations, specifically in long-term care. And the surgical dressing policy allows people who have Medicare benefits, Part B, not Part A, but Part B benefits. So you have to understand your Part A's and your Part B's. It allows them to get dressings for what's called a surgical wound. Now, it doesn't have to be a wound from surgery. It could be that the wound had surgery, it opened, and now it's dehisced, and now we have a hard to heal wound. It can be a wound from anything when you look at the Part B guidelines, but you have to have done certain things to even access the Part B benefits. If you're trying to get dressings, for instance, you have to have done debridement. You have to be sure that you document certain things to be able to even access And this is important because Part B benefits, when we access Part B benefits, particularly in long-term care, that person's Medicare that they paid into their whole life pays for that, for the Part B dressings. They'll pay for the dressings if it's documented appropriately. If not, CMS isn't going to pay for them. So we have to watch our documentation. So there are some really good things about this. However, like I said, it doesn't cover Part A. Part A is covered in the entire however much money that building gets for that person's stay. They have to take the dressings out of that. And the dressings can become very, very expensive for some of these wounds. So we have our Part A, our Part B. Part B is the surgical dressing policy that does give us access. There are good things and bad things. And I'm going to say there are more good things about the surgical dressing policy than bad things. But some of the and like I said, bad things, barriers is the right word. Some of the ways some of the things are written in the surgical dressing policy becomes a barrier for our patients with wounds that are a little bit outside of the box of what Medicare thinks is reasonable and necessary. And they are reasonable and necessary, but sometimes not according to CMS perspective. And then there can be denials for getting these dressings. So they're good things, and there are challenges with the surgical dressing policies, Welly. That's the bottom line.
Absolutely. On previous podcasts, a common theme that's come up is the idea of the Pareto rule, right? Where 80% of patients are going to resolve fairly easily. And I use that word very loosely. But then
Yeah, right.
there's 20% of patients are incredibly expensive, very difficult to get their wounds to resolve.
Yes.
And it's been a common theme that the regulations sometimes over accentuate the 80% without
Yes.
thinking about the 20% where those rules may not be as useful or fruitful.
Yes. Yes.
And so, it's a discussion point amongst experts because that 20% is where you guys really excel and think about a lot of the time.
Yes. That's true.
The other thing, maybe we can go down another rabbit hole a little bit. We got about 18 minutes left.
Okay.
F686, post
F686.
acute, right?
Yes.
Anyone's been in post acute knows what F686 is, or what before it was F314. What do you think about the F686 rule as it stands right now, regulation?
All
And
right. I'm glad you asked. Go ahead. And
and in the future, because again, they're going to iterate, how do you think it will change?
this is a fabulous question. As you mentioned, all right, so what is F686? F686 comes out of State Operations Manual Guidance to Surveyors. This is the guidelines for skin integrity. It's the skin integrity tag specifically for pressure injuries, not for other wounds. F686 is only about pressure injuries. Prevention, half the program, half this document is on prevention of pressure injuries, and the other half is on assessment and healing of pressure injuries, the things that we need to do. When it was F314, it had way too many holes in it. I don't know who wrote the original, I can't tell you. But F686, I do know some of the clinical wound professionals who helped CMS to write F686, and it improved 80%. And that happened I think it was in 2017 when we got the new regulations. 2017, I think it was something around. They do redo them about every 5 years. So when we got the new F686 in 2017, and each year they may update it a little bit. We had a nice update about every 5 years. We have a nice update for 2023 in F686. So in F666, this is the regulations that tells you how wound prevention and management should be done clinically and regulatorily in your buildings. And this is for the post-acute care setting, specifically for long-term care, nursing facilities. The problem is the nursing facility leadership and treatment people don't read F686, which is too bad because it's the framework of what the surveyor is going to do, and it has incredible information on wound prevention and management. It is clinically very relevant if you will sit down and learn that document. It's an excellent guidance for people who have no wound experience. And in long-term care, many of our treatment nurses are just thrown to the wolves and say, you are now the treatment nurse, the DON says. And this person has never taken a course. They've never read a paper. They've not been given a protocol on what they're supposed to do. So F686, when you have people who do not know wound management and long-term care, this is one of the documents they need. The other one is the minimum data set, the MDS, which tells this is the coding and reporting that we have to do for long-term care. We have to report every single thing on this person that comes into our buildings. So the MDS has other fabulous education, and you have to report your wounds according to what the MDS guides you to do. And in that document is excellent education on pressure injuries. So the guidelines, they are trying to get us to help us with these guidelines. But the problem is some of us in the industry don't read what we've been asked to do, that we're supposed to do. That's part of the problem, is we don't recognize, pardon me, the importance of these regulatory guidelines that do address clinical practice. And part of that is on us, the people in the buildings, because we haven't read it. And we're not doing what CMS has told us. And so, Ellie, when I read this document at first, when I first started reading this, when I first came to long-term care, and I heard about the State Operations Manual Guidance to Surveyors and F686, and that they wrote all these guidelines, my thought was, what does the federal government know about wounds? What does the federal government know about pressure injuries? But when I got into the document, especially the last F686, I could tell that they had help. CMS, federal government, had help from clinicians who know wound management. And I think it's a good document at this point.
No, it's absolutely fascinating. And in my travels, I've talked to people who work in post acute in Germany, the United Kingdom, in South Africa, Japan. And what's remarkable about the American system is that regulatory framework around pressure ulcers.
Yes.
It's like you said, in its application, at times we may disagree, but having a framework
A
of
framework.
expectations really does help to up the standard of care that goes to residents. So,
Yes. And I asked the buildings to use that document, the MDS document, to frame their protocols in their buildings. If you frame it around the regulations, you're not going to get F tags. And that it doesn't mean failure, although it is. F means federal. It's a federal tag, 686.
uh, that's absolutely fascinating. I know for some listeners, there might be some inside baseball, but I think, post acute is such a big part of the wound care community that I just wanted to go down that road a little bit because I just think it's absolutely fascinating. So we've got about 12 minutes, and talking about post acute, I know one of the areas that is really capturing your attention and capturing the attention of many people is end of life ulcerations. There's been a lot of discussion around this amongst many communities. We are working on issues around this. Could you perhaps take us down that road and talk about your interest, its impact, and its import in your mind?
Yes, I can. And I am so passionate about this. Thank you very much for asking. This is one of the biggest, it should be one of the biggest topics in the post-acute care setting. Especially, it's going to be very prevalent in long-term care and home health, where people go to do their work of dying. That's Joyce Black, The Work of Dying. So it's this process. When we talk about failure, organ failure, skin failure, end-of-life wounds, we have three types. We have acute, which you'll see in ICU, or you might see a person has a myocardial infarction. They have a heart attack. They drop dead. That's acute organ failure. What we see in the post-acute setting more often is chronic organ failure that goes along with chronic diseases and chronic skin failure. And then we have end-stage organ failure at the end of life, which happens in everywhere. It happens everywhere. So when we look at the non-healing wounds, some of the wounds that aren't healing, and are people who have multi-organ involvement, oftentimes what we're calling a pressure injury is an end-of-life wound, is what it is. And we're looking at that hole in that patient or resident in long-term care, and we're not looking at the whole patient, and we miss the organs that are failing. There's 11 organ systems. I separate the muscular system from the skeletal system because they have two different purposes and do different things at a cellular and tissue base. So We have 11 organ systems. The skin is one of those 11 systems. Any organ failure from other 10 systems is going to affect the skin. We are not looking at the organs. So what I teach my providers, what I teach my bedside clinicians is we need to get capture all the ICD-10 codes, every single organ that is in failure. So when the skin fails at end of life or other times, think about those toes, those little black toes from arterial insufficiency. That's organ failure. The vascular system is failing. We do not have chronic wounds in our bodies, Welly, unless there is some organ involvement. Maybe you get a wound that has an infection and we may be able to clear the infection. If we can't clear the infection, is it because it's a multi-resistant drug organism, or is it because that person's immune system is in failure? So we have to look at everything. What is happening is we are calling organ failure. We're seeing these wounds come up. It is actually associated with, say, congestive heart failure. They have congestive heart failure. I'm going to give you the example of an unavoidable pressure injury. According to CMS, and the unavoidability term is only within CMS. That comes from CMS, from the regulations. I'm going to give you the example of an unavoidable pressure injury, a real pressure injury that's unavoidable. So this person has end-stage congestive heart failure. They are on the maximum amount of oxygen that they can have through the cannula. They have to have the head of the bed up so that they can drain their lung fields, because as their congestive heart failure progresses, the lungs begin to fill up. And of course, this person goes into end-stage congestive heart failure and they die. It's actually, so the purpose I'm telling you this is when you bring the head of the bed up to drain the lung fields, this person is going to be resting on their sacrum. They're going to be resting on their sacrum. Can't help it. So I need my provider, my primary care physician, my wound care physician, to write an order to keep the head of the bed to 70, 80. And why? To facilitate breathing. And that this person might get an unavoidable pressure injury because they need to stay in this position to facilitate breathing. And another consideration that I'm just going to throw in here is when you think about the angiosomes that are coming off the source arteries and you think about the sacrum only has one angiosome. Not like the buttocks that have many, many angiosomes to provide vascularity. So the sacrum is vascularly challenged to begin with. And then you have a low pulse ox, the pulse oximetry, systemic oxygen is maybe below 90%. So now we have low systemic oxygen and this person has to stay in this position. There's not going to be any way to avoid a pressure injury. So that is a true unavoidable pressure injury. But what we're seeing with end of life is where these wounds are coming up, the buildings aren't looking at the whole patient. They're only looking at the hole in the patient, and they're calling it a pressure injury. They're getting F tags they don't deserve. And when we get the etiology wrong for a wound, Zoeli, any etiology, when we get the etiology incorrect, most of the time we're putting in the incorrect treatment options. So say you're calling something a pressure injury, but really and truly it has to do with end of life. You're treating for the pressure injury, but you're not taking care of some of the other things. And part of that needs to be the conversation with the family, the patient, about the end of life journey. And we're not doing these conversations early enough. And the families are getting mad and they're suing us for things that have nothing to do with what we did or didn't do. It has to do with the fact that the patient is in failure. Systemic organ failure.
No, absolutely. And um, I've seen real world impacts of that miscategorization or misdiagnosis. It's an end of life pressure ulcer, the patient passes. It was classified as a pressure ulcer. Family gets upset, a lawsuit ensues. Then an expert comes in and evaluates the whole case and goes, there was organ failure, right? So now we have the situation where it's in the legal system, and at that point, it's not about science, it's
No.
about who can make the best argument.
Yeah, right.
Exactly. And so the implication of end of life is just an enormous issue in post acute. And I'm glad that we have someone like you and people like you working on that subject. And, we've been working on that subject with you as well to kind of say, okay, how are we defining this from a research perspective? And I think it's an incredibly important conversation that's happening in post acute with very real world implications. And some of these settlements that we're seeing in that community if you evaluate what really happened, some of these should not have happened, and some of them
Yeah.
should have because it's extreme cases of neglect.
There are.
Right.
There is negligence occasionally, but what they're attaching to negligence isn't negligence most of the time. It has to do with overall failure of the body. I know somebody recently that settled a lawsuit. They were not at fault, but they went ahead and settled. And when you go back and look, it looks like this provider group, it was at fault for something. They were not. They were said, we should just settle and not go to court. So that's another thing that is happening, is because just what you said, it's not about the science anymore. It's about how it appears. It's a surface thing, how it appears. It's not about the science of what's happening beneath.
Well, it gets even more interesting. People think about those settlements at the end of the day. What also happens is that the insurance companies assign a value to what you could have potentially have lost. Now,
Yes.
this is what people don't know. That follows you even if you settle at an amount less than that. So there are massive implications in terms of
Yes.
cost. And that forces provider groups to make the choice between bringing on another great clinician or
Mm-hmm.
paying an insurance bill, right?
That's right.
And, you know, at the end of the day, if that choice is made, that's another 1,000 patients that are not treated, you know. And I think, again, the work you do is so valuable. I lived in that world and I know the import of it and the real choices that people have to make in terms of care for patients. So we have about 3 minutes and 30 seconds left. A question that I love asking our guests, and you've been a fantastic guest. I've learned so much in the past 50 minutes. If we were to do a wound care Arabian Nights and we had
Mhm.
a wound genie that could grant any of your wound care wishes, what one thing would you wish for out of the milieu of things that you're involved with and doing?
What is one thing that I would wish for Pamela, or
For Pamela, for the community,
for the
one
community?
thing, if you could be granted one wish.
If I could be granted one wish for the wound management community and for our patients and residents who need this level of expertise, it would be for all of our wound specialists to go through the process of becoming board certified by an accredited board certification process. The reason for this is we know we've been around people that are educated to do wounds and are not educated to do wounds, and the care is at the opposite end of the spectrums. So the board certification process makes sure you have a leveling field of knowledge. We all have the same knowledge. Doesn't matter what your credential is. A wound does not heal by credential. A wound heals by care. We need more board certified wound care clinicians. And when you go through the board certification, you get the basics of what wound management should be when you go through a good course. The problem we're having as well, and I'll just mention it real quickly, is we have all these wound courses that are popping up and they say they're certified, but they're not. They took a course, they got a certificate of completion. It's not accredited. So you keep hearing me say accredited. That means that board exam has gone through a process that questions are written according to a structure for well-written questions. So that's why I keep saying accredited, because we only have three. And we have all these things are being taught, and they're not being taught by people who have gone through a course. So anyway, if do you think that's a good answer? I mean, there's so many things, like you said, there's so many things we could do. Like I wish we had access to all these wonderful technologies, to uh, uh, the ability to get these technologies easily to our patients. The new technologies, we're struggling to even get the new technologies in some instances to people who would respond to them, but we don't have all the resources or the wherewithal to get some of these technologies. So like I said, there's many, many things, but what do you think about the answer about board certification? Do you think that would be important to this audience? Because it's my passion doesn't mean it's going to be everybody else's passion.
I think what you're touching on is to your first point. This is a specialty,
Specialty.
and a specialty absent guardrails is not a specialty. It's that
That's
simple.
okay.
And
Yeah.
it's be it a school, be it anything worth anything has guardrails, and there's gatekeeping of some sort. And so I think if we're really going to make wound care a specialty in the truest sense of
We
the
want it to
word,
be respected. And that's what
exactly.
we want is you. If you have when you have somebody that's a WOCN, they're credited, they're respected, and so we have wound certification credentials for all clinicians now, not just a nurse. When it first started, it was only for nursing. WOCN, wound ostomy continence nurse. The physical therapist, the physicians went to the WOCN, said, we want to be certified. Yes. They said, no, you see that N in there, it's for nursing only. That's why we have the American Board of Wound Management, because the nurses didn't want to integrate with us, which is good. They can keep their in their lane. The ABWM, the CWS, CWCA, and CWSP is interdisciplinary, and then we have another one that's an interdisciplinary credential. The WCC is also interdisciplinary. So the fact that we all have someplace to go to get an accredited board certification, there's no excuse not to. As a matter of fact, if you want to do wound management, you're hamstringing yourself if you don't go get a certification because you didn't get field leveling information. You don't know the basics of wound management. And then when you get your certification, I have to work within my practice act as a physical therapist. My providers, my nurse practitioners, physicians, physician assistants, diabetic, podiatrists, they work within their specialty to apply what their practice acts allow them to do. But we all need the same information to be sure that we're all heading in the right direction. And that's from the education we give, the knowledge we gain, and then the certification process to show that we have at least gone through a leveling field of knowledge. Doesn't mean you're a great clinician, but it means you got some of the education, and that you didn't just decide to hang up a sign says that you're a wound physician or nurse or physical therapist, that you actually did the education process to gain some knowledge.
No, absolutely. Well, Pamela, this has been absolutely fantastic. I think our viewers and our listeners are going to appreciate the specificity, the breadth of knowledge that you've brought to the podcast. And frankly, I enjoyed talking a little bit of inside baseball on post acute. So thank you so much for your time, and I truly
You,
appreciate it.
this was very, very meaningful. Thank you so much. You take good care.
Likewise, thank you.
Thank you.